Hey, good morning, everyone. This is Sonia at Mettle Health. Just wanted to check in, say thanks, and introduce you to our two guest hosts today. We are lucky enough to have Bridget and Kana, who are going to walk us through the differences between palliative care and hospice care. Bridget is a licensed clinical social worker who has worked across settings, providing support and companionship to patients, families, community members, and providers. And on top of her clinical work, she's also a writer and educator and edited Palliative Care, a guide for health social workers. And Kana McKee is a palliative care physician who has cared for seriously ill individuals and their families in the hospital, as well as outpatient and clinic settings. And she's dedicated to helping those with serious illness live with the best quality of life possible. So thank you both so much for being here and speaking with us. Kana, if you could just advance to the next slide, I'll give everyone questions.
Okay.
All right, perfect. All right, just a quick FYI on how you guys can check in with us after Bridget and Kana have kind of gone through the slides. There's two ways that you can ask questions. You can click the raise your hand button up at the top and we will unmute you and you can ask your question out loud. And if you would prefer to not ask it out loud or would like to remain anonymous, you can type your question in at the bottom and one of us, I will probably me, will read it out and Kana and Bridget can address it that way. So raise your hand, ask it verbally or type it in. And again, if you would like to remain anonymous, please just let us know. That's no problem. We will try to get through all the questions within the hour, but if not, please know that we'll do a little separate recording to address those questions and everything will be recorded and posted on our YouTube page. So thanks again for being here and I'll hand it over to Bridget and Kana.
All right, thanks, Sonia.
Okay.
So, go ahead, Bridget.
Yeah. Well, we're really happy to be here with you today. It's a treat for Kana and I to get to be together in this space. And, you know, we're going to provide sort of some scaffolding, some information around how we think about palliative medicine, and then palliative care and hospice specifically. And, you know, we're mostly really excited to get to your questions, to understand sort of how this lives for you and what you're curious about. This is such an important topic and so near and dear to our hearts because confusion around the differences between palliative care services and hospice services are the most common. Lots of people are confused about this. And so we want to talk a little bit about the relationship between palliative care and hospice and make sure that you understand in general what the differences are, noting that we could have an audience from all over the country and there are some regional differences just in terms of what's available. So happy to be here and really happy to get to your questions.
So we wanted to just start out by defining what palliative care is. And Bridget and I will kind of talk together to try to give, you know, a broad overview of what we consider to be palliative care and palliative medicine. So, you know, the definition of palliative care is that it's an approach to patients and families where we are really focused on improving the quality of life of patients and families who are living with a serious illness. And that can be a focus on relieving the physical signs and symptoms and, you know, treating the various physical symptoms like pain, nausea and vomiting, constipation, you know, physical manifestations of their illness or the treatments that they're going through. But it also means addressing the psychosocial, spiritual, and cultural aspects of patients and their experience of living with an illness.
And I think just when we start to talk about this and you think about like, what does this mean? This means thinking about a whole person, thinking about the individual and their experience, the experience of the folks around them of having a serious illness. When you say it out loud, it's sort of like, why is this a specialty? This should really just be medicine. And I think for many of us in the field, that's the dream. And maybe we'll see it in this lifetime, and maybe we won't. But palliative medicine as a field is really interested in caring for the human experience of having an illness. And palliative care and hospice do that sort of at different times and at different stages, potentially.
Yeah. One of the questions that we commonly get about palliative care when we talk about serious illness is, what's considered a serious illness? So I think one of the most common ones that come to people's minds is something like advanced cancer. But a serious illness can be really, any illness that is potentially life-limiting or really burdensome in terms of the, suffering that's associated with it. So in palliative medicine, we commonly see patients with advanced cancer, but also things like, heart failure, advanced lung disease like COPD or pulmonary fibrosis, advanced kidney disease, neurologic disease like Parkinson's or ALS, or, progressive dementia. So it really, can be something that's helpful to patients and families who are living with a variety of serious illnesses.
And I think later in life, it's not uncommon for folks to not necessarily have a serious illness diagnosis, but for friends and family to notice that things are changing. Maybe there's more emergency room visits, maybe things are less manageable at home and someone's eating less or moving around less. And while that doesn't necessarily fall into a diagnostic box, with older age, that might be a perfect time to get some version of palliative care involved.
Yeah. And I think, one of the things that we haven't mentioned before is the focus really is on whole person care and really getting to understand what's important to that individual and that family. Because people are so different when it comes to, what's most important and what they hope for and what they worry about. And so a really important aspect of palliative care is taking those things into account. So understanding what's important to people, what their values are, what their goals are, and helping to make sure that their medical treatments are really aligned with those goals and values. And so I would say that an important part of palliative care is clarifying people's goals and values, and then helping with medical decision making, and also things like advanced care planning to make sure that the care that they get really is tailored to what's important.
And part of doing that well means understanding how the person in front of you and the person in their and the people in their lives communicate about these things, because it's not all the same. Some folks really want direct information with really explicit choices about what options are, and other people speak more in metaphor or aren't going to talk directly about their diagnoses. And so the brilliantly tricky part of our jobs is figuring out how to support the people in front of us and to match their communication style and communication needs.
Okay, I'm going to advance the slides.
Great.
Yeah.
So sort of in the spirit of what we're talking about, sort of trying to take care of a whole person, the field of palliative medicine, which really came out of the grassroots hospice movement, is a team sport. So in many places, when you receive either palliative care or hospice, always when you're receiving hospice, you will be supported by a social worker, chaplain, nurse, doctor, and at times, depending on settings, a CNA or a PCA. And this is because we are humbly aware that not one of us can necessarily hold all of these pieces. And while Kana may take a deeper dive into pain management, I might get more into family dynamics. And we share that information in order to take better care of whole people.
Mm-hmm. And I also think of, palliative care as really partnering with patients' other healthcare providers. So one of the things that I emphasize is, we don't replace anybody. So when I'm meeting a patient for the first time or a family, I try to be clear that I'm not taking over and replacing anybody, their primary care doctor, their heart failure doctor, their oncologist, but I'm really working alongside them and collaborating with them to make sure that you, the patient, get the best care possible. So that's kind of how I think about it too, is that within palliative care, it's a team sport, but really we're aligned with all kinds of other providers involved in patients and families' care to provide the best quality of life possible.
And on our best days, inpatient and on an inpatient setting for palliative care, the palliative care team might sort of act as that quarterback. So bringing lots of different perspectives together to try and sort of craft a whole picture around what's happening. And to sort of Kana's point earlier, getting out of some of the minutia details of what kind of treatments are possible, so that we can talk about what's our bigger picture, what are we sort of going for here, and then crafting those interventions to make sure it's towards that vision.
So I wanted to talk a little bit about palliative care, what you're getting and how and where it's delivered. In terms of what you're getting, we've already kind of talked about many of those aspects. I think a couple of things I wanted to highlight is that there's often a sense that, palliative care is only for people who are, really near the end of life. Their time is very short. They're not getting other treatments. That's not actually true. So palliative care is, as I said, appropriate for patients with a serious illness diagnosis, but really, from the time of diagnosis throughout, their journey of living with it. So regardless of what the goal is, sometimes, many times, the goal might be cure, and people might be really interested in going through pretty aggressive treatments to get to that goal of cure. Other times cure isn't possible, but there's a very, focused goal to try to live as long as possible. Palliative care can support patients with that goal. And then for those people who really are experiencing disease progressing and getting sicker, palliative care can be a part of that care as they enter those last stages and near the end of life. And I think the other thing to highlight too is that, patients can be of all ages. So, from pediatric patients all the way to patients who are, elderly. So it's really, I think a much broader target than what people typically associate when they hear palliative care. Yeah,
totally. And because of the relationship between palliative care and hospice, I think the sort of number one association that we are often met with is folks thinking that palliative care is being recommended because you're dying. And it's very much not necessarily the case. Could be, but most commonly it's because there's some illness that's creating a challenge to quality of life. And a role to try and help folks feel better, cope better, understand what's happening better. And there is no requirement around prognosis, which is one of the really defining differences between palliative care services and hospice services.
Absolutely. Yeah, oftentimes the way that I talk about it is, palliative care's focus is really on helping people live as well as possible, rather than the emphasis being on death and dying. So, yeah. So, in terms of what does it actually look like? How can you access palliative care? To some extent, it depends on where you are and what the healthcare sort of systems are like in your area. But there's a couple of different settings in which palliative care is frequently delivered. The first is the inpatient setting. So in the hospital, when a patient is hospitalized, most hospitals will have a palliative care consult service, meaning a team of palliative care, doctors, nurses, social workers, chaplains who can visit patients who are hospitalized and provide consultative services in the hospital. The other type of setting is in the outpatient or clinic setting, where patients who are living with a serious illness but who are not hospitalized can go to a clinic and talk with a palliative care provider and get ongoing support and care longitudinally. And then less common is our home-based palliative care programs. I would say there aren't that many of them. Sometimes they are available through home health. And then finally, I think, as people are going through different transitions in their health, palliative care can be a part of helping folks sort of figure out, the timing of transitions and then the services that they can then access at different points in that trajectory.
Mm-hmm. And I think then the other piece is, how do you access it, right? So if it's there, and sort of overwhelmingly, palliative care services are most commonly available in the hospital. The clinic world is developing, and the at-home world is even more in development. But often a physician who's already taking care of you might suspect that it would be helpful and recommend a consult. But also you can ask for it. And the awareness of palliative care in the consumer world is not that high still. And so advocating for yourself, if you find yourself in the hospital feeling like some part of your experience isn't being tended to, or you're uncomfortable, or you need help sort of processing what's going on, asking about what palliative care services are available there, and if you can talk to somebody.
Great.
Yeah.
All right.
So hospice care is in many ways the sort of more established of the two sets of services. It is regulated by Medicare and Medi-Cal or Medicaid nationally, and is really the sort of most robust benefit to many insurance plans, meaning that the care you get is covered by your insurance, and it works to be the sort of most comprehensive and wraparound services that you can have outside of the hospital. Some of the biggest differences between hospice and palliative care is that hospice does have a prognostic requirement. And what does that mean? That means that to a best estimate or guess, physicians involved in your care believe that, or the care of a loved one or family member, that your lifespan would be 6 months or less. And folks get super hooked up on that means for sure you're going to die in less than 6 months, that if you don't die in 6 months, you don't get services anymore. And a little piece of the history that I just think is so interesting is that 6 months was chosen by lawmakers because they knew that this kind of all-inclusive or encompassing benefit wouldn't be sort of funded or approved if it was for any length of time. And so 6 months doesn't have anything to do with medicine or actually what dying means. It has to do with bureaucracy. And that just feels important to keep in mind, because what is dying? How long are you dying? Like, these are all much bigger questions than a law or even medicine can answer. But it is a requirement for accessing the service. it happens most commonly at home. And home could be many places. It could be an actual residence. It could be a residential care facility. It could be a boarding care. It could be assisted living. It could be a skilled nursing facility. But overwhelmingly, hospice is in the community or in the place that someone lives. Hospice teams, which are really nurse driven, that's the person that you will for sure see the most and have the most contact with, are available 24 hours a day, but they don't move into your house 24 hours a day. And that's, I think, another super common point of confusion. One being folks think you go somewhere for hospice. And secondly being that somebody's in your house all of the time. And I'd say there's like equally camps of people that are really disappointed to hear that someone's not moving into your house full time to be a caregiver, and then another cadre of folks that are just like very relieved to know that somebody is not going to be in their business all the time. So available 24/7, team-based but nurse-led. Completely covered by insurance most of the time. Certainly if you have Medicare and Medicaid, and most of the time otherwise, including all of your medicines, all of your equipment, most of your supplies. And I think another big piece of hospice is, this idea that it's sort of expert symptom management for sort of end stage disease and dying. And then also emotional, psychological, spiritual, cultural support for the dying person and the folks around them. A lot of education around sort of what's about to happen so that folks can recognize changes in people's bodies and have some sense sort of what's coming if that's desired. And then the care continues through bereavement. So hospices offer bereavement care for surviving folks for 13 months after someone has died. And that 13 months was crafted to sort of make it through all of the first anniversaries. What am I forgetting, Kana? There's so much.
There's so much to talk about. I think one of the things, Bridget mentioned that one of the things that defines hospice within that overall umbrella or, bigger circle of palliative care is the prognostic, less than 6 months element. Also, like philosophically, the focus of the care becomes more purely on symptom management and support. And it's generally for patients who are no longer pursuing, really, cancer care or treatments that are directed at their main diagnosis. So there's nuances to that because, for example, in heart failure, a lot of the heart failure medications are actually important in the management of symptoms. So we don't need to get into the weeds, but I think that's another element where, palliative care generally, earlier on in someone's disease course happens alongside and, along with disease-directed treatments. In hospice care, really the focus of care is on managing the symptoms associated with that illness and helping to make sure that people are well supported and it's comfortable and have the best quality of life possible so they can continue to get the most out of every day. But, the focus is shifting away from trying to diagnose what's happening or doing lots of, testing or procedures. So it is a shift in that direction.
I think a really common piece of that shift is the hope to try and stay out of the hospital or to stay out of a facility. And that's part of the 24-hour availability. If you're at home and you have ongoing pain related to a cancer diagnosis and something changes with that pain in the middle of the night, the hospice wants to be available to you so that you don't end up in the emergency room. Again, these things become sort of less black and white all of the time. And it doesn't mean you could never go back to the hospital. You are always free to call 911, if that's within your desire. But in general, if we're thinking about trying to match somebody to a service that really feels aligned with what they're hoping for, trying to stay out of the hospital is pretty central to hospice.
Yeah. Okay, I think those were most of the things that we kind of wanted to talk about to start the conversation. But I know you're all out there with.
Yes, get us out of our, Zoom or webinar void and talk to us about what your experiences are, your more nuanced questions.
Okay, great. Thanks, guys. We do have some questions that have come in, so I'll just
okay. I'll stop showing this screen.
Oh, perfect. Thanks.
I did that right. Okay.
You did.
There we go.
Yeah,
perfect. Yeah.
Now I can see you guys. Well, see Bridget.
So the first question. Let's see here. So the first question is, if a family wants to have less direct contact, maybe minimal visits from hospice, they should just say so?
Yeah, totally.
Basically, yeah. I would say, when you're first enrolling in hospice, the team really wants to get to know you, right? So there's many members of a hospice team, not just the nurse. So I think in the beginning, I tell my patients, like in the beginning, it's going to potentially feel like a lot of visits because the nurse will want to come and meet you and talk over your needs and make sure that you have what you need. The social worker will want to meet you, the chaplain, so it might feel like a lot, but ultimately the goal is to figure out what the patient's needs are and the family's needs are, and then to figure out the pace of visits and the frequency of visits. And so you should feel really empowered to let your needs be known. It's a requirement that hospice nurses evaluate patients at least once every 2 weeks. And a typical schedule is they would come and check in and do a visit once a week. And then depending on what the needs are, it may be more, it may be less. Bridget, what do you have to add to that?
Yeah, totally. I think that when we think about needs, if one of your needs is to have less people in your house, then you should feel free to share that. And maybe to hold some openness to the fact that might change, right? At first, you don't have a need for a lot of visits, and then depending on what's happening, more visits may feel supportive, and the best hospice team will be able to really accommodate and adapt to that.
Yeah. One of the things too is sometimes patients and families will say, well, I don't have that many needs yet, and I'm not sure when's the right time, and maybe it'll be the right time when I really need help. And to some extent, yeah, like if you have 0 needs, maybe that's not the time. But on the other hand, it's really nice when you get to know the hospice team and they get to know you before you're really in a crisis, having uncontrolled symptoms or having something really stressful happen, unexpectedly. So I think that there is an advantage to getting to know a hospice team before someone is really, in dire need, because then, when they know you, they can really jump in quickly without, all the time and legwork it takes to really get to know somebody.
Okay, great. Next question, also about hospice. Are end-of-life options integrated with hospice? When my brother with ALS opted for end-of-life options, his hospice folks were not as informed as he proceeded with his options. Is this a legal requirement, or was this just the policy of his healthcare system?
So slightly tricky to talk about because there's different laws in different states around what in California we would refer to as the End of Life Option Act. which are sort of the group of laws, medical aid in dying, the group of laws that allow you to take the time of your death a bit more into your own hands. Healthcare organizations, and kind of don't totally correct me if I'm wrong, have the right to sort of opting in or out of participating in access to medical aid in dying. Commonly here in California and in the Bay Area, most hospices participate on some level. But I think that this is still new in a lot of places and not accessible in many. And so the fact that there might be variation in terms of what the hospice team understands or what the hospice team is able to do is not surprising to me. I'm sorry that your brother had that experience, that he didn't get the kind of, and your family didn't necessarily get the support or feel like the folks in and around his care had the information that you all needed. I can imagine that was disappointing among a lot of other things. So I guess my answer is just that, like, I think there's still a huge amount of variation there. What do you think, Kana?
I agree. Yeah. And I think, you know, like I think the California experience is, you know, each hospice was trying to figure out how they were going to, you know, whether they were going to participate, to what degree, or not at all, figuring out what their role is, you know, in the whole process, because it's often a process that may have started even before they became involved, or may, you know, start during the time that a patient is on hospice. So I think, you know, asking questions, if that's something that you know is going to be important to you or to a family member, I think just gathering information and asking questions is you know, always my advice. I think the other thing too is, you know, there's lots of different, I mean, it depends on where you live. In some, you know, locations, there may be lots of hospices around. They can be nonprofit hospices, for-profit hospices, hospices that have been around for decades, hospices that are pretty new. And sometimes, you know, it can be pretty daunting to figure out, you know, which is the one I should choose. You know, if you're already connected to like a palliative care doctor or a team, that's a good place to go to say, hey, you know, do you have a recommendation for me? Here are the things that I feel would be important to me that I'd be looking for, and they might be able to, you know, make some recommendations. Or, you know, a local, you know, your primary care doctor may have some recommendations. So I think asking for information is okay. And I think ultimately too, it's important to know that you're never, if you decide to enroll with a hospice agency, you're not stuck with that forever if you decide that it's not a good fit. Sometimes the fit is like your hospice nurse is not a good fit for you as an individual, and just asking to be reassigned to another nurse might be, you know, the thing that's needed. Or it may be that, you know, what that hospice agency has to offer is not a good fit. Now, generally, like most hospices are required to provide a certain set of basic, you know, there's basic requirements in order to be a certified hospice agency. But in terms of what that actually looks like, you know, your lived experience of being cared for them, that might be different. So, yeah.
Yeah, the conversation around medical aid in dying is so complicated because there's huge regional variation. And, you know, I heard a lawyer in California describe it once as, just because the law has passed does not make it anyone's right, which kind of gets into the nuance between like what feels like should be our choice medically versus what we are absolutely entitled to. And, you know, there are requirements to these laws that have to be met and have to be met at certain times. And it is far from perfect and often can feel pretty tricky to get all of the timing right. So in truth, it's probably another whole hour or many hours of conversation. But not totally surprising that there was some variation, what you expected and got.
Thanks, guys. Okay, this next one, also about hospice. I have heard that many people enter hospice with just a few days of life left when it might have been beneficial for them to enroll much sooner. Can you please speak to that? And do you have any thoughts or suggestions about educating people about enrolling in hospice sooner when appropriate?
I would say that's probably the common experience, unfortunately. I think I haven't looked at this data recently, but if we think about the prognostic criteria, a prognosis of 6 months or less makes you eligible for hospice. And I think at some point in the last few years, the average length of stay for a hospice was something like 21 or 28 days. It's not very long. And that means you got some outliers who are hanging out for sort of months, and you got a lot of folks who are sort of on service for days to a week or weeks. And that's symptomatic, I think, to your question of there not being widespread information about hospice. There being a lot of myth around what hospice is and when it's available. And providers like cardiologists or oncologists or specialists, even primary care doctors that don't know enough or don't feel comfortable recommending it. In the setting of a culture that likes to treat illness and treat it for a really long time. So part of it, I think, is educating providers, and part of it is educating consumers, you all presumably, or many of you, so that you know how to ask for what is available to you. What else? It also feels like a really big, it's like a big cultural issue in a lot of ways.
Yeah. I mean, I think, from the standpoint of someone, the person who is ill or a family member, I think one of the hardest things when you're talking to doctors is to figure out, like, if you're talking, like, let's take cancer as an example. Like, let's say someone has advanced lung cancer and it's, metastatic disease. They've tried different treatments. The treatment that they've been on is no longer working. And, when you're talking with the doctor, there may be other treatments that potentially could be tried. And I think the key thing here is trying to understand what that treatment is going to get you, because there may be other treatments, but there comes a time when potentially doing that treatment can make you even sicker. The chemotherapy itself might make you sicker and make your time shorter than actually not doing that chemotherapy and really focus on trying to manage symptoms as well as possible so that, people can function. So, but that can often be pretty difficult to tease out. And I think asking that question can often remind the doctors, like, what is it that we're going for? It's not, is it to exhaust every single possible treatment that's available? Or is it to, try to live as long as possible? And sometimes the answer to trying to live as long as possible is avoiding the complications that come from treatment. Sometimes the answer to trying to live as long as possible may be trying a treatment for a limited, kind of trial period of time to see whether it helps and see what the side effects are. I think that can be sometimes a tricky part of figuring out when is it the right time to enroll in hospice. And I think, when we are doing palliative care in the clinic setting, when we are seeing patients in the hospital setting, that's a lot of what we're thinking about, both together with patients, but also with the teams of doctors that are treating them. And potentially talking about, what's the next step? Is it more treatment, or is it not? I don't know whether that answers the question, but that's a really big question, and a lot of what we are thinking about as we take care of folks.
Great. Okay, next one. This person says, I was working with a spouse whose wife had advanced dementia and he was denied hospice services several times. What are some of the symptoms that would indicate one is ready and, more importantly, eligible for hospice?
So every disease process or diagnosis has different criteria that makes you eligible for hospice, in addition to a limited prognosis. And so advanced dementia is a really tricky one, because your dementia, what we consider to be advanced dementia in our lives, is actually could be quite different than what is medically considered advanced dementia. And so people have to be, you know, I think for hospice and dementia, it's still based on a FAST score, which includes, speaking very few words, not feeding oneself, like, sort of a very, very, very advanced dementia. And so I think people with dementias have, this is a common experience where they think like, okay, we don't want to go to the hospital anymore. We don't want to interrupt what's happening in this person's body. We want to make sure they're comfortable. Let's get a hospice involved. And then you've come to find out that actually this person doesn't meet criteria because they have to be sort of even farther down the road than you'd expect.
Yeah, exactly. And the FAST scale, it's really most appropriate for people who have Alzheimer's dementia. There's other types of dementia that have sort of a different kind of pace and progression. But when we're talking about the FAST scale, which is short for the functional assessment scale, to be hospice eligible based on that, I mean, people have to be essentially bedbound, not able to really speak more than 6 intelligible words. They can't really sit up on their own. They need help eating. It's a really, really advanced stage, and I think that's often really hard for patients and particularly their families and caregivers who are philosophically really aligned and could benefit from hospice, and yet find that their loved one isn't quite at that stage where they would prognostically be certifiable for hospice care.
I think the other thing you see with folks with dementia or Alzheimer's dementia, and then also just sort of older adults who maybe don't have a specific diagnosis, but there's been notable decline, is that sometimes folks like have a sort of drop off and they join a hospice service and then they kind of stabilize again. And so you hear of people with dementia graduating from their hospice service, which means that they've stopped meeting the criteria to stay on a hospice program. And this is a super hard transition, very frustrating often for family members and caregivers, because it's sort of the last thing you expect when you get a hospice service involved. But it does happen. And I think both of these instances sort of just show the imperfectness of this system. And, there are efforts to be changing access and availability to hospice to be a little bit less rigid around some of these diagnostic criteria. So hopefully we continue to see that change for the better.
Okay, great. Next one is about palliative care. Does insurance often cover palliative care? I can't imagine it is a big moneymaker for hospitals or systems. So where does the funding come from?
Great question. Also variation. In general, I think it's pretty safe to say that palliative care services, while you are in the hospital, are covered. They end up sort of in that bundled cost. And for the most part, things aren't being added to your hospital stay that you're going to see a unique bill for. So covered inpatient gets trickier with clinic. And I don't think there's a good universal answer around whether it's covered or not. What do you think, Kana?
I don't think that there is. And the other thing too, and one of the frustrations, outpatient clinic-based palliative care is one of the, I mean, it is the fastest growing portion of palliative care, because inpatient services are pretty established and pretty, you know, consistently available. Clinics are not. So both in terms of like figuring out whether it's covered by your insurance, but also figuring out whether it's available in sort of the healthcare system in which you are. Those are things that are going to vary.
And I'll say many clinics that exist do pre-authorizations with your insurance, so you should know before your visit if it's covered or not. And if you haven't been told that, and just please ask, because there should be clinic staff that can answer that question for you, so you don't get a surprise bill.
Mm-hmm.
Okay, great. Next up is about the actual care force. What avenues do hospice workers have to process their grief?
That's a really good question. You know, and Bridget, I'm sure you'll have things to add, but you know, hospice teams are really a team. So all hospices will have meetings where the entire care team is together to talk about the patients that they're caring for. And I do think that as a field, you know, the way that they work to support patients, it translates into how they support each other. So I do think that there are built-in, you know, ways for members of a hospice team to connect and talk about the things that have been challenging, both in patient care, but also in terms of how they're coping and holding all of that. So again, I think, you know, different hospice teams and hospice agencies will have what they, you know, differences in what they do. But I think in terms of being able to sustain in the work, it's a really important part of it. And thank you for that question. I think it's a great, and I think it's something that we all honestly need. It's not just a hospice team, you know, or a palliative care team. I think everyone in healthcare really needs more opportunities to be able to share, you know, the feelings, the emotions, the impact, you know, that caring for seriously ill patients has. You know, doctors are not, and healthcare providers aren't robots, and they shouldn't be. And emotional processing, and I think connection is a really, really important part of being able to sustain and be present, and yeah.
Yeah, I think that, you know, the field of palliative medicine, or the field of palliative care at large, is, you know, at its heart and theoretically really committed to resiliency, because our workforce is relatively small compared to the need, or extremely small compared to the need, and the hope is to be able to keep people in the work. And I think, as is true with many things in palliative care, the way that we are doing things or thinking about things are hopefully ways that kind of catch on in healthcare in general. And we are far from perfect for, you know, in trying to figure out how to process what it is to be with illness and dying much of the time. And every person in the field has really unique needs. So some people want to sit around with their team and process, and other people don't. And they go to church, or they go to their yoga mat, or they go to playing with their kids. And so part of it is, I think, about facilitating space for each, you know, worker to have that awareness for themselves around what they need. I think it also changes. I can just speak really personally, which is like, what I needed to make sense of this work 5 years ago is super different than what I need now. And I imagine it'll be even more different could be next week, but could be another 5 years, right? It's just something that continuously changes depending on what's happening in your life.
Okay, we've got 2 more questions, and one of these has a little bit of background information, so I'm just going to read this off and then we can get to the question. So she says, as an end-of-life doula supporting a family with late-stage cancer at home, It was rather than the hospice doctor calling the shots, it was the oncologist. And this greatly impacted the care since the doctor was still trying to treat symptoms. Example being fluid retention. Patient strongly resisted going to have the fluid drained, but the doctor insisted. Then doctor tried to insist on a second procedure and the patient refused to go. He died 2 days later and the fluid issue completely resolved itself. We did call early on to ask the hospice doctor if she felt this procedure was necessary, but she kept deferring to the oncologist. How can you advocate in a situation like this?
That is a really good question. I mean,
I wonder, Kana, do you think that's I guess there's probably a huge regional variation, as you'll probably be sick of hearing me say at some point. I wonder what the data says about if that's the norm, having the oncologist as the primary physician involved in the hospice care. I think hypothetically, every hospice should have a medical director that's available to be the primary doctor, or at least that's a common occurrence if it's not a requirement.
I think I'm hesitating in my answer because that's
Yeah.
not a common situation. So I think one thing is to know is that, you know, like all hospices have hospice physicians and a hospice medical director. And the most common scenario is that when someone enrolls in hospice, the hospice medical director really together working with the nurses and all the members of the team, you know, are reviewing the medical aspects of the patient's care, looking at the medications, you know, thinking about if procedures are felt to be really important to symptom management, thinking about whether that is something that can be done and kind of thinking through those things. So they are usually the main physician helping to guide the different sort of ways in which symptom management is delivered by a hospice team, right? Patients are often worried that enrolling in hospice means they're going to be cut off from the doctors, their primary care doctor, their oncologist that they had gotten to know so well and trust. And so one thing that I tell people is, you know, you can actually name your primary care doctor or oncologist if they're willing to be a doctor that the hospice agency will give updates to. And, you know, as an outpatient palliative care physician, sometimes I've had hospice medical directors reach out to me to say, hey, do you want to have input into the medication changes that I make? Like, do you want to collaborate on that? Sometimes, but oftentimes, more often, I ask to be kept in the loop, but to ask the hospice team to take the lead because they are able to see my patient in the home. They're able to do these evaluations and really, you know, are expert in managing those symptoms at the end of life. So even as a palliative care physician, I'm not really usually inserting myself into those decisions unless I think that I can have a helpful impact. I think it's even more rare for oncologists to be trying to drive the care in this, you know, in a similar way that you're describing.
So I guess like if we were sort of like go back to that scenario, I guess my question would be, or an option would be saying to that hospice medical director, can you take this over? I see that you're deferring to this oncologist and we don't know how he or she or they got that role, but we would like you to have that role now. Because that feels like the piece of information that's missing. Like, could they not because of that system? Were they deferring because they thought that the patient wanted the oncologist sort of central to the care still? And so I think that's probably something I would have done in hindsight, is ask, can you take this over? It sounds like they were just deferring, but could they have had the more explicit role of sort of in charge?
Yeah, I think it's just like feeling empowered to be able to say no to things and to say, I want you to drive my care. thank you, and I don't want to do this intervention anymore.
Yeah.
And you know, I think the thing is, you know, one of my mentors so early on in my career said, all doctors love their patients. You know, all doctors want the best for their patients. It's just that the way that in which that is expressed can be different sometimes. And I can imagine that oncologists felt really committed to your patient, you know, really wanted to do what he or she thought would help the patient you were taking care of. It's just that that opinion was not aligned with what your patient actually needed at that time. So I think the intention was probably good. It's just that it wasn't the right match for that point in time.
Yeah.
Great. Okay, we have one final question, which is perfect timing wise. And this one is, how does palliative care versus hospice work with dementia? So I think, how would hospice approach a dementia patient versus palliative care?
Yeah, so I can take a stab first and then Bridget jump in. So again, you know, dementia is often a progressive illness where people decline very slowly, often over many, many years. And certainly over the disease trajectory, there can be times when there's like a major change and then someone bounces back a bit. But palliative care for someone who has dementia can be involved in a number of ways, like earlier on, like maybe when someone is first diagnosed with dementia or is really starting to notice the impact of dementia on life. Palliative care can help people get a better understanding of what to expect and anticipate, you know, what's expected to happen in the next couple of months versus what are some typical changes that can be expected over years, you know, for someone living with that illness. Palliative care can be a part of helping patients while they still have that ability, or maybe if it's later on, helping families think about who this person is and what kind of care, you know, he or she, they would want, and helping to think about ways of either putting that down on paper, like in, you know, advanced healthcare directives, or making it, you know, clear to all of the providers who are involved, you know, in the medical care. So, you know, providing anticipatory guidance, helping with sort of advanced healthcare decision making. As people progress in their illness and have higher needs, it might be, you know, kind of checking in with caregivers and seeing how they're coping, seeing whether there are, you know, sort of supportive services that are available and not yet being accessed. Those kinds of things I think a palliative care team could help with. I think at the point when hospice becomes involved in someone's care with dementia, usually that patient is in a very, very advanced stage of dementia, right? And so a hospice team may help with providing like medical equipment or like equipment like hospital beds or other types of equipment. They might be helping caregivers sort of understand what's happening. By oftentimes patients at that stage have problems with swallowing and aspiration, or, you know, they're bedbound and maybe maybe at risk of developing wounds, you know, so a hospice team might be really tending to those physical needs, the caregiver's needs, providing medications for symptom management. I think it would be kind of more of a focus on that rather than doing like advanced care planning at that point. I think there's still a lot of need for anticipatory guidance and helping caregivers and families understand what are the changes, you know, they're seeing in their loved one, and helping to guide them on that.
Yeah, I know we're just about at time, so I'll try and be really brief. I think that I will just say humbly that palliative care is young in figuring out the best way to support and be involved with all of the different diagnoses that exist as serious illnesses. And I think we're at a really beginning stage of figuring out how to support people with dementia. And all of the types of dementia. You know, while we commonly talk about palliative care being available from diagnosis and beyond, that might not make sense if prognosis is 10 years, right? We might not have the staffing to do that. So I guess I'll just say humbly that I think we're really in the thick of figuring it out, especially around dementia and longer, more slowly progressing neurologic conditions. And part of us figuring out how to do it well is learning from people who are living with these conditions or who have lived with these conditions to figure out, you know, at what points, what kind of support is needed. And working really closely with our neurology colleagues, because they have keys we don't have in a lot of ways for something like that around symptom management over time, like the behavioral dynamics of dementia. So we're in the thick of trying to figure it out, which I think we will be for a while, but are very committed to it.
Thank you guys so much. I know we're at time here, so I want to be respectful of everyone's day, but that was wonderful. And thank you so much for being here. And thank you everyone for attending, and hope everyone has a great weekend.
Great, thank you.
Thank
Bye, guys.
you.
Bye.